The Knowledgeable Provider podcast is intended primarily to entertain, also to inform, but it is not a substitute for actual medical training and should not be used by anyone to diagnose or treat any medical condition in themselves or others. If you need medical advice, please make an appointment to see your own knowledgeable medical provider. The opinions expressed by me and anyone else who happens to appear on the podcast are solely those of the people expressing them and are not necessarily representative of any other entities. Other than the lunches at the office, I do not receive any sort of compensation from pharmaceutical or medical device companies, and I have no other relevant financial disclosures. Look, this is all for fun, okay? Don't sue me. All right, on with the show. So iron is something that's important to us in medicine. It plays a lot of important roles in the body, the most important of which is arguably forming red blood cells. And blood is the thing that's pretty important to us in medicine. I think it's fair to say all the time. All of our patients get a CBC every year with their annual physical, and I order iron studies pretty frequently. It's not a part of the routine lab panel, but of course, we have a pretty low threshold of ordering that when there's any kind of symptoms or processes that would suggest anemia or blood loss. And with those iron studies, every single time when one of them comes back abnormal, I have to stop and go, all right, what does all this mean? What's the transferrin and what's the TIBC and what's the transferrin saturation, blah, blah, blah. So I decided to devote an entire episode just to iron. Iron is not only important to humans, it's pretty important to any sort of living organism. According to an article I found from the Journal of Research in Medical Sciences from February of 2014, we know that iron had different medicinal uses dating back to the ancient civilizations. Apparently back in the 17th century, so the 1600s, it was used specifically to treat chlorosis, aka green disease, which was a condition that apparently resulted from deficiency of iron. So then I had to look up chlorosis because I was having trouble imagining what might turn someone green. And apparently that was just what they used to call iron deficiency anemia. So I'm not sure where the green part would come from. I can see maybe a condition that made you jaundice, like maybe if they mistook some gallbladder or liver issue for iron deficiency. I don't know. That's interesting. But anyway, iron's been used for a long time, and it's been recognized as an important part of human physiology for a long time. Of course, we know that its most important job is to be used in the production of hemoglobin and myoglobin, but there are also other enzymes involved in electron transport and oxidation reduction reactions that are made from iron. Most of the iron in the body is bound up in the hemoglobin, roughly 2/3, and the rest of it's kind of stored away for rainy day in our little storehouses that we have throughout the body. Of that, most of it is in the liver, but there's also some stored in the spleen and muscle tissue and bone marrow. I'm not really much of a numbers person, but if you care, the normal amount of iron in the body at any given time should be around 3 to 4 grams total. So about 2.5 grams in the hemoglobin, 300 or 400 milligrams in iron-containing proteins. That would be the myoglobin and the different enzymes that I mentioned. 3 to 4 milligrams are riding around on the transferrin proteins at any given time. And the rest of it is stored actually in the form of either ferritin or hemosiderin. There are a whole lot of different proteins that affect iron balance. I'm only going to talk about the ones that we actually use in interpreting iron studies. The UpToDate section on iron balance actually lists like over 20 different individual proteins that have something to do with iron balance. So it really is a much more complicated process. And I like to understand the mechanism behind things in the body. I feel like that's much more useful than just sort of memorizing what the lab test results mean. I feel like that's how we learn for tests. And then we dump that information right on out of our brain as soon as the test is over. And by test, I mean tests that we take in school in our training. But for me, if I actually understand the mechanism behind something, I can look at the test results as in lab test results and really genuinely understand what I'm looking at and understand what the abnormalities mean. I don't always put a lot of history and background and stuff about physiology in my lectures for the nursing students. But when I do, I think they hate it. I think they pretty much want to know what's on the test, right? As in the academic assessment that they're getting ready to take. And I get that. I think I've moaned about that here on the podcast before. I think we're all like that to some degree when we're students. But I hope everybody's overriding goal in medical training is to actually learn about medicine and the human body. And gosh, it's so freaking complicated. The more you learn about it, the more you realize how much there is and how much you don't know. So anyway, my goal is always to understand the mechanism behind these things but then also to understand it in a way that's simple enough that my little brain can comprehend it. And just a side note for teaching, especially precepting students or doing clinical rotations with groups of students, if you're called on to explain things, you really find the gaps in your own knowledge. And it's super embarrassing when somebody asks you questions you really don't know the answer to. Of course, that happens with patients as well. So those moments are very helpful for learning things if you've ever thought about precepting students and haven't tried it yet, or working as a clinical instructor. It's very beneficial not only for the students, but for you personally. All right, I digress. Back to iron. Like pretty much everything else in the body, there has to be a balance. We need to have our warehouses full of iron, so we need to have enough of it, but we don't need to have too much of it floating around, or that causes its own set of problems. So the body has to do something to maintain an appropriate balance of iron. We don't manufacture iron within our bodies, so we have to get it in our diet. So it's important to think about how that whole cycle takes place. The major place where iron absorption is regulated, of course, is in the gut, where it happens. Of course, we have to get plenty of iron in our diet. If we're not taking any in, obviously we can't absorb any. Things that have a lot of iron in them are things that have blood. So red meat's probably the biggest single source of iron. Other kinds of meats, including fish, poultry, shellfish, are iron-rich. Liver, a lot of iron is stored in the liver. So if you've ever eaten liver, it has a sort of unique taste, sort of metallic, I guess. And that would probably be from all the iron that's stored inside it. Dark green leafy vegetables are another great source of iron, like spinach or collard greens. But the iron that you get from plant sources is a little bit different than the iron you get from animal sources, and it's actually harder for the body to absorb. So with our patients who don't eat meat, that is an important consideration for them to make sure that they're getting enough iron in their diet. A lot of cereals, like breakfast cereals, are fortified with iron, so there's some extra iron in that. Tofu, beans, dried fruit, egg yolks, and tomato paste are some other specific things that are good sources of iron. Of course, you can find much more in-depth lists of this online. If you have access to UpToDate, the article on causes and diagnosis of iron deficiency has a very long table of different foods and their respective iron contents. There are some foods that interfere with iron absorption. Examples of that include tannates, which are found in tea, phosphates, phytates, which are found in whole grains and seeds, and things that have a lot of calcium in them. Of course, it would be unusual for iron deficiency to develop just because you eat a lot of those things. That's one of those things that you would not think of immediately as being a common cause of iron deficiency. Apparently, there was a case report of a person who became iron deficient just because they drank a lot of tea. Apparently, they drank like 1.5 liters of tea every day for like 20 years. But in general, that's not going to be a major cause of iron deficiency. Other things that can interfere with iron absorption are things that affect the upper GI tract. Most iron is absorbed in the duodenum. So if you have celiac disease, autoimmune gastritis, H. pylori, or if you've had some kind of surgery that affects the area, like bariatric surgery, the pH of that area has a lot to do with iron absorption. So one of the big concerns about PPIs, proton pump inhibitors like omeprazole, esomeprazole, etc., are that they interfere with iron absorption. Also, people who take a lot of over-the-counter antacids, a lot of those contain a bunch of calcium, so that's kind of a double whammy there. Another iatrogenic thing that can cause iron deficiency is people who are treated with erythropoietin, EPO, for anemia associated with chronic kidney disease. That will actually cause a shift in iron stores and iron distribution. And iron deficiency in chronic kidney disease is like a whole other thing. That's like a whole other topic I'm not really going to get into much. But if you work in nephrology or if you're taking care of a lot of patients with CKD, you may want to pay some attention to that separately from just the normal discussion of iron. We mostly think of iron deficiency as an absolute iron deficiency, as in there's just not enough iron. But you can get what's called a functional iron deficiency, where you actually have enough iron, but it's not available for production of red blood cells. So that's how that works with the EPO. The patients have the iron, but they can't release it quick enough from storage to keep up with the demand for creating new red blood cells. And that's the same situation with people who have anemia of chronic disease or anemia of inflammation. Remember, we don't generate iron within our bodies, but we do recycle it, mostly from the breakdown of red blood cells. And so with chronic disease or chronic inflammation, we have a problem getting that iron back into the circulation after it's recycled. So the iron is in the body, but it's not available to do what we need it to do, really, which is make red blood cells. That's kind of a parallel with glucose and people who are diabetics. They have a lot of glucose, but either they don't have the insulin or they have too much insulin resistance for the insulin to get the glucose into the cells. So it's there, but it's useless. So those are the less common things that affect the absorption and recycling of iron. By far, the most common reason that we see iron deficiency is because we're losing it. And the most common way to do that, remember, most of the iron is contained within the red blood cells, and so we lose blood, and thus we're also losing iron. So any of the various ways that we can lose blood from our body put us at risk of and cause iron deficiency anemia. Females actually have generally lower levels of iron in their bodies because they lose blood on a roughly monthly basis. And then pregnancy and breastfeeding can also have an effect on iron. I would think that means that after menopause, the iron levels in males and females should be roughly equivalent, but I don't know that for sure. I haven't seen that in any of the stuff I've read to prepare for this. And of course, in general, when we suspect somebody's losing blood and we don't know the source of it, as in we can't see it gushing out of them or they're not telling us it's gushing out of them, the first place we look is in the GI tract. And of course, we know there are a ton of different things that can cause bleeding in the GI tract, including diseases, medications, etc. Other ways that a person might lose blood would be from donating blood frequently, so they're giving it away. We have one patient that is a religious blood donor, and he's always teetering on the verge of being iron deficient, and he's always very concerned about it. So every time he comes in, we have to have the conversation about iron deficiency and check his blood count to see if his levels are high enough that they will let him donate. For people who have to have a bunch of lab testing, I think we don't always pay attention to how much blood we're pulling out of people in the acute care setting. It's always labs and labs and labs and more labs and more labs. And in the adult population, usually that's not as big of a deal. When I worked in pediatrics, we were a little bit more conscious of it just because it's very obvious that the infant you're pulling blood out of does not have a whole lot of blood to give you in the first place. But it is possible to pull so much blood out of somebody that you iatrogenically cause significant blood loss. And of course, if somebody's in the hospital and sick, they might be prone to iron deficiency / anemia for other reasons as well. One thing that might trip us up is difficulty estimating how much blood loss there is. Famously, we struggle to accurately tell how much blood we're looking at when we're looking at it outside the body. Patients will see blood in the toilet and act like they're bleeding to death. But it can also happen that somebody underestimates the amount of blood that they're losing. So a female who's used to having heavy menstrual periods might not really even think of that as heavy. And if we're talking to her about it, we may not really get a sense of how much blood she's actually losing every month. And then again, for the folks on dialysis, they can lose iron directly that way. So in a nutshell, that's an overview of what iron is and how it's used in the body and things that can make us not have enough of it. So now I want to get into how we assess this with lab tests, with the iron studies. So the labs that we think of, the labs that I order when I do iron studies are iron, ferritin, TIBC, which is total iron binding capacity. And then from those numbers, we get the transferrin saturation. You may hear that called TSAT. On our lab reports, it just says iron saturation percentage. And then, of course, we have the blood count itself, which will tell us something about how many red blood cells there are, and also what they look like or how big they are, both of which are big clues about anemia and its underlying causes. So I'll go through one by one and talk about what each of those things mean and represent. The iron level typically is going to be the iron in serum, or it can be measured in plasma. That tells you how much iron is in circulation, not how much is locked up in the blood cells, but how much is actually riding around on the transferrin transport proteins. Ferritin, to me, is the one that's a little bit confusing. So ferritin is a protein that stores iron. So the iron that's not locked up in the blood cells, that's not riding around on transferrin, is mostly stored as ferritin. And to some degree, the ferritin level goes up and down along with the amount of iron that's stored in the body. So one thing that you will see is sometimes people will just check the ferritin level and use that as a proxy for whether or not a person is iron deficient. But unfortunately, ferritin is not quite that simple. It is also an acute phase reactant, meaning that it will increase when other things are going on. So if there's some inflammatory thing, some sickness, whatever, the ferritin level will go up even if the amount of iron in the body is not changing. So you can see how that might be misleading if somebody is sick with a chronic disease that might be making them anemic, but then you check the ferritin level and it's normal. So you go, oh, this is not iron deficiency, but it could still be iron deficiency. So my practice generally is just to order all of these things. Every once in a while, I'll just order a ferritin. I guess that would be in situations where I'm trying to rule out iron deficiency among other things, but I really don't think it's iron deficiency, or I don't see any confounding factors that would be affecting the ferritin level. But usually I like to just order all these things together if I'm worried about iron. TIBC, total iron binding capacity. That means how much transferrin is currently available to bind and transport iron. You can actually check the serum transferrin level directly, and then you multiply that by a factor to get to the total iron binding capacity, TIBC. I don't think our lab reports have the transferrin level. I think it just has TIBC. So I always think of transferrin like transfer trucks. They're little transporters that are floating around the blood, and their whole job is to transport iron from one place to another. So the TIBC is how many trucks you have available that could potentially be loaded with iron if needed. So if a person is iron deficient, for whatever reason there's not enough iron, that means there are going to be more empty trucks driving around. So the TIBC goes up. There's more potential space for iron to go because more of those trucks are empty than should be. Or if you had the opposite situation, iron overload, more of the trucks would be loaded than should be loaded. So that's how you can think about the total iron binding capacity, TIBC. And then transferrin saturation is a way to look at the same thing, but just put in a percentage. So the way that's calculated is you take the serum iron, divide it by the total iron binding capacity, and then multiply it by 100 to turn it into a percentage. So that would be pretty easy to calculate if your lab doesn't report the transferrin saturation for whatever reason. So if you think about a situation where a person is actually iron deficient, the serum iron should be lower, and the total iron binding capacity, TIBC, should be higher. So we're dividing the serum iron by the TIBC, which makes the transferrin saturation number lower. Transferrin saturation goes down. So to summarize the way I think about all this, the iron level is just how much iron there is, not in the red blood cells, but in the transfer trucks, the transferrin. The TIBC is how many trucks are available to transport iron if needed, so how many empty trucks are there, and then the transferrin saturation is what percentage of the trucks are loaded with iron. So with iron deficiency, the serum iron is low, the TIBC is high, and the transferrin saturation, or TSAT, is low. Of course, it's not really that simple. There are a lot of other factors that can affect these results, and so I was looking for images or tables that summarize this briefly. And so most of these will say, like, so in this condition, this factor could be high or it could be normal. In this situation, it could be low or it could be normal. So there's a lot of other variables there. Iron deficiency is pretty straightforward. That's the most likely one to give you a straightforward result on the iron studies, I think. If you have anemia of chronic disease or thalassemia or iron deficiency on top of anemia of chronic disease, then those results become a little bit more hazy and tricky. But for just very straightforward iron deficiency, that is what you should see with the iron studies. And then when we look at the CBC, the complete blood count, obviously this is not as specific to iron as the iron studies, and the results on the CBC tend to lag behind the iron studies a little bit. So we very commonly see patients who are a little bit deficient of iron, but then when you look on their CBC, they're not anemic because of it. And so things that we look for on the CBC to suggest iron deficiency are low red blood cell count, low hemoglobin and hematocrit, low absolute reticulocyte count, and then low mean corpuscular volume, MCV, or mean corpuscular hemoglobin. All those things should be low with iron deficiency if it's progressed to the point that it's causing some anemia. The way I think about that is it's easy to tell if somebody's anemic, right? The H&H is low. The red blood cell count is low. It's a little bit trickier to tell why they're anemic. And I think the MCV is a great key to look at for that. Iron deficiency is going to cause a microcytic anemia, meaning that the red blood cells are going to get smaller. So the MCV is low. So when you have anemia and you have a low MCV, immediately think iron deficiency. If it goes the other way, the red blood cells are too big, so the MCV is high. You want to think about other causes like B12 or folic acid deficiency. But with iron deficiency anemia, it should be low. I mentioned thalassemia a minute ago. I'm not really going to go into that too much, but the red blood cell count is useful for distinguishing iron deficiency from thalassemia. Thalassemia can also cause a microcytic anemia due to reduced production of some of the structural elements that go into making the red blood cells. But a person with thalassemia is not going to have a low red blood cell count in the absence of any other confounding factor. That should be either normal or high. So that makes sense, right? If you have little red blood cells because of a defect in how they're made and not because of iron deficiency, the MCV would be low, but the actual amount of red blood cells would be fine. One other thing on the CBC you might see is increased platelets with iron deficiency. It seems like the mechanism for that is not quite clear. It's definitely not clear to me. So with pure iron deficiency, the two things that should be elevated or that might be elevated are the platelets and the TIBC. All the other things we look at should be low. There are some other tests that are available for iron deficiency, but they're not commonly ordered. I don't think I've ever seen any of these ordered, so I'm not going to talk about them. It's always good to think about things that can confound test results, that can interfere with our lab tests. It's a good idea to test iron in the fasting state if you're really worried about it, because obviously a person's dietary intake of iron, or if they're taking iron supplements, would affect the serum iron and therefore the transferrin saturation TSAT. And of course, if somebody's getting IV iron treatments, that is going to increase both the serum iron and the TSAT. So the guidance there is to wait about 4 weeks after a dose of IV iron to recheck the iron studies and the CBC. Clinical manifestations, typically by the time we're having symptoms, that means we have progressed to anemia. So the things that we're actually going to see in patients or be told by patients are going to be due to iron deficiency that is severe enough that it has progressed to them actually being anemic. Probably the big one is fatigue. It's kind of the bane of our existence in family practice. Everybody complains of being tired. But when somebody truly has a new onset of fatigue or a precipitous worsening of fatigue, anemia is definitely something you think about there. And so along with just fatigue in general, of course, it makes sense. If you don't have enough blood to carry oxygen around, of course, you're going to be fatigued. You're not going to have good exercise tolerance. You're going to get short of breath, feel weak, etc. So almost like some of the same symptoms you think of with cardiac disease or lung disease. I always remember I took care of a guy on the ambulance one time. I went and picked him up at a church, and he was, I'm going to guess, mid-60s, very overweight, like someone you wouldn't be surprised if they were having a heart attack. And he was pale, diaphoretic, lethargic, really looked like crap. And the only reason I remember him is that we got in the back of the ambulance, and I think I had underestimated how alert he really was. And so being at church, he was dressed up. He had a button-down shirt on. And I was worried enough about this guy that I was like in a hurry. And so instead of carefully unbuttoning each button, I just grabbed a hold of his shirt, Hollywood style, and ripped it open, tore all the buttons off. They go flying across the ambulance. Ping, ping, ping. Well, that's when I found out how awake this guy really was. He gave me the nastiest go to hell look. And I was very embarrassed. And of course, found out later that he was not having a heart attack, but he was in fact anemic. I don't know why, but that's always stuck in my brain as a good example of how sick somebody with anemia really can look. Another big thing with anemia is pica, which of course means eating things that are not food or craving things that are not food. And specifically with anemia is ice. The actual name for that is pagophagia, craving ice. I was listening to an episode of the Curbsiders podcast about iron one time, and the specialist they were talking to specifically mentioned that. He said, when you see one of these patients, make sure you ask them if they're craving ice, and they will think you're super smart or something to that effect. Because that's a weird thing that you wouldn't necessarily associate with anemia just off the top of your head, but that is something you commonly see. Restless leg syndrome is another thing that may manifest as a symptom of anemia. The other name for restless leg syndrome is Willis-Ekborn disease. I think I just learned that right now. I'd rather tell somebody they have restless leg syndrome than Willis-Ekborn disease. But shout out to, I assume, Dr. Willis and Dr. Ekborn. Obviously, that's not specific to anemia. A lot of people have restless legs. But if that is something you see a new onset of, one of the things you'd want to rule out there would be anemia. There's this other phenomenon called beeturia, where if you eat beets, it will turn your urine red if you are iron deficient. That also is not specific for iron deficiency, but apparently happens in between 50 to 80% of people who have iron deficiency. The mechanism there is that the red pigment in beets is decolorized when it interacts with iron. So typically it gets absorbed from the GI tract and interacts with ferric ions, and it becomes less red. But when there's not enough iron around, that process doesn't happen. So it remains red, and it comes out red in your urine. Other things people may report are mood changes, hearing loss. As far as physical exam findings, I already mentioned the pale diaphoretic look. This is one of those things that can give you glossitis, so smooth tongue without the appropriate papillae, chelosis or angular cheilitis, so the little rashes at the corner of the mouth, spoon nails, which is called koilonychia, which is exactly what it sounds like. The nails grow in a sort of concave shape that looks like a spoon. An esophageal web, very rare. Also hair loss, very rare. And here is the explanation for the chlorosis. People can take on a pale, faintly green complexion, which is very rare. So it's interesting to think that back in the day, they probably didn't recognize all the common symptoms of iron deficiency. So when someone came along that was green, it makes sense that they would name the disease after that. So we've run across a patient that has iron deficiency. What do we do about it? Probably most commonly we see this without anemia. So the iron level's low, but they're not anemic. Do we treat those people? Do we not treat those people? I would err on the side of treating them. Of course, if they are having any symptoms that you might attribute to the iron deficiency. But in general, I think it's a good idea to replenish that if you do find that it's low. And then, of course, in the back of your mind, you should be asking yourself, why is their iron low? Do they have some kind of thing that's affecting absorption, which we already talked about? And then if they do have anemia, of course, you really have to think about, okay, where are they losing blood or what's the underlying cause of this here? when we're just talking about treating iron deficiency itself, pretty much comes down to either oral iron or IV iron. My approach is usually to start with oral iron, but the thing about that is it's poorly tolerated. It causes GI upset in a lot of people. A lot of folks can't tolerate it. And I found that's one of those things that you should specifically ask about, because people will sort of imply or tell you that they are taking their iron, but they may not mention that it tears their stomach up, so they only take it every 3 days or whatever. I have patients that do fine on oral iron, but it's one of those things kind of like metformin, where it's very, very likely that it will cause some kind of GI upset. So I recommend asking directly about that for people who are on iron. According to this article I'm looking at, up to 70% of patients treated with oral iron will report some sort of GI side effect. If they can't tolerate it, then you can always send them for an iron infusion. Of course, we all learn about being super careful with IV iron and being very alert for any anaphylaxis that may be caused by IV iron. Apparently, that was more associated with older preparations, specifically high molecular weight iron dextran. That is actually not on the market anymore. The forms that are available now should be much safer. So in my practice, typically I write for ferrous sulfate, 325 milligrams, which is 65 milligrams of elemental iron. And then if they can't tolerate that, I'll send them to hematology to start doing infusions. There are a bunch of different forms of oral iron, sort of like calcium and magnesium. There's all kinds of different versions of it. There's ferric citrate, ferric maltol, ferrous fumarate, ferrous gluconate, and polysaccharide iron complex. I don't really have any particular reason for picking the ferrous sulfate other than I can remember the 325 milligram dose because it's the same as adult aspirin. And I guess that's really all I've ever seen used in clinical settings commonly. There are a bunch of other iron preparations that people can take over the counter. As far as I can tell, there's not a great deal of evidence for choosing one of these over the other. I love the sentence about this in the UpToDate article. It says, numerous oral iron formulations are available, and for the most part, all are equally effective as long as they are taken. Good one, UpToDate. So if there's any issue with cost, really the recommendation here would just be to pick the cheapest one for the patient. It's probably a good idea to stay away from any kind of enteric-coated or sustained release capsules. A lot of times those make it further down in the gut than the duodenum before they release the iron, so it makes it harder for it to be absorbed. The same kind of thing is true with the IV iron. There are several different preparations that you can choose from. I don't order these or know anything about them, so I'm not going to jump into that at all. And this is another thing that differs significantly if you have somebody with chronic kidney disease, and then varies more based on whether or not they are on dialysis. I know that a lot of times you will see patients feel significantly better and have significant reductions in their symptoms pretty soon after they get a dose of IV iron. The amount they get and the frequency of the dosing kind of depends on the patient and the situation and how bad the anemia is. So I don't think there's really a standard frequency there. I tend to just leave that up to my friendly neighborhood hematologist. And then hopefully, of course, you can do something to fix the underlying problem if there's blood loss or whatever else is going on, and not just have to keep sending people for iron infusions or keep feeding them supplemental iron for their whole life. And that is easy to do, by the way. This is one of those things that sometimes iron gets put on a patient's med list, and then you just sort of have it in your brain that they're taking iron and you refill it every year. And it's easy to do something like that without really ever thinking about what the underlying issue is. So I always encourage you to take the next step and think about the cause of whatever problem it is that you're treating. I will say a little bit about iron overload. There's not really a specific mechanism for the body to get rid of iron other than just using it. You know, with a lot of the things we learn about with feedback loops and maintenance of homeostasis of various things, there's usually some mechanism for the kidneys to get rid of whatever it is, or the liver to get rid of whatever it is, or there's some way that the losses match the intake. With iron, the only way we really get rid of it is to use it, to make stuff or store it, which of course is not getting rid of it, but it is getting it out of the bloodstream. So we have to be a bit careful when we're giving people iron that we're not giving them too much. We actually do lose a little bit of iron through sweat and skin cells that we shed, and a little bit through the GI tract, really only equivalent to about half or 1 milligram per day. Apparently a typical Western diet, we should get about 10 to 20 milligrams of iron, and roughly 10% of that is going to be absorbed in the GI tract. So really the only way to have too much iron is to take in too much of it, whether that's in the diet or iatrogenically, as in we're giving you too much iron. So people who have to get blood transfusions regularly for whatever reason are very prone to this. Of course, people who are receiving either oral or probably more likely IV iron would be prone to this if we mess up. You can also have a situation where too much of it is absorbed in the gut. Conditions that cause that include alcoholic liver disease, chronic hepatitis, different kinds of anemias that cause ineffective erythropoiesis, and hemochromatosis that's due to this particular gene mutation. Of course, it's possible to have a double whammy. If you're somebody that has thalassemia, which remember causes a problem with erythropoiesis, you might have to go get blood transfusions, and you're also prone to absorbing more iron in your gut. So 2 reasons why somebody with thalassemia might be prone to iron overload. So what happens if we have too much iron? Well, eventually it fills up all the transfer trucks and all the warehouses that we have available, and it starts binding to other things. Iron by itself is never just freely roaming around in the body. It's always bound to something. So if there aren't any of its little transport trucks available, it'll start binding to albumin, citrate, acetate, and other things. And that actually starts to happen after the TSAT gets over 35%, and really happens after the TSAT is above 70%. And so once that starts happening, then it starts being taken up by different cell types that are capable of absorbing it, which include cells in the liver and heart and endocrine organs. And once it's in there, something chemistry, and you end up getting these reactive oxygen species, free radicals, that start causing tissue damage. So by the time any kind of clinical manifestations appear, that means you've kind of gotten to the point where your liver or your heart are damaged. So why else would we think about testing somebody for iron overload? Really, it would only be in those patients that are predisposed to it. So people with those underlying conditions or who are being treated with iron. As far as testing for this, of course, it's the same test we've already discussed. You're just going to see the opposite results of what we've been talking about for deficiency. You can also see excessive iron in the body if you have iron deposits in the heart or the liver or some other tissues, including the pancreas and the pituitary gland. You can actually see that with an MRI. I guess you'd really only do that if you had a patient that you already knew was iron overloaded and you want to see how prone they were to damage or how much iron might already be visible in those organs. I guess this could also be something that would show up as an incidental finding on an MRI that was done for something else and could clue you into the fact that a patient has iron overload. But hopefully it would not progress to that point without anybody noticing it. Really, the ultimate way to find out about iron overload would be to get a liver biopsy. And again, you can see how that might show up as an incidental finding on somebody who's getting a biopsy for something else. And the same would apply for any other tissue that's prone to accumulating iron. If you biopsied that particular tissue, you would be able to see the iron. So what do we do about iron overload once we find it? Kind of the 2 options are phlebotomy and chelation therapy. It seems like the things that are available in the United States for chelation therapy are deferoxamine, deferaprone, and deferocyrox. Of course, no idea if I'm pronouncing this correctly or not. I don't feel like it's super important for me to know the specifics of those, so I will link an article in the show notes about the different chelators. One thing I will say is if you're treating somebody who has acute iron poisoning, as in they've had a single massive ingestion of iron and are like in the emergency room now and need to be treated, deferoxamine is the one you'd want to go with. That works by binding up iron in the blood to form a water-soluble molecule that can then be peed away by the kidneys. Once the iron is taken up by the cells, it's not really amenable to chelation therapy. So this has to be given really early on with an acute iron poisoning situation. The same would be true of doing something like dialysis to get iron out of the blood. Once it's in the cells, that wouldn't work. Anything like that has to be started early. I guess the options that have been tried there are exchange transfusions and CVVH, both of which do work, but of course have a high level of complications and blah, blah, blah. So I think that's really all I have to say. Kind of tired of talking about iron now, so I'm going to stop. I will list all my sources for you in the show notes, including the link to the article I mentioned about chelator therapy. Most of what I read was from UpToDate. If you have access to Lippincott Advisor for Education, that's a really good source for sort of quick and dirty bullet point lists about everything, really. They had pretty good sections on the iron studies. I didn't end up using them for the episode, really, but I did look at them. And then, of course, Hippocrates is always a great resource for looking at the individual labs and giving you just basics, highlights about whatever you're looking for. So I recommend all of those if you're looking for more information about this. If you have any questions, if you have anything to add or hear anything that I said that was wrong, feel free to send an email. It's thekppod@gmail.com. That's thekppod@gmail.com. All right, that does it for this episode of Knowledgeable Provider. I'm your host, Jody Marks. Thank you so much for listening. Don't forget to like or subscribe or follow and leave a nice 5-star review. And as always, stay safe, take care of yourself, and take care of your patients, in that order.